Now let me invite our next speaker, Dr. Deepika. She is consultant glaucoma surgeon from MNI Hospital, Chennai.
Good afternoon, everyone. Thanks for the invite, Preeta and Gemini. So, coming to acute emergencies in glaucoma, there are only a few emergencies in glaucoma, but they are very, very important. So, first and foremost goes acute angle closure attack, which is the primary pupillary block. So, from PG rays, as we know, two of the only main emergencies in ocular emergencies will be, one is acute angle closure attack and CRAO, because you have to intervene immediately, cater to the condition immediately, otherwise it can lead to irreversible blindness. So pupillary block can also be caused due to other causes secondarily, which can be silicone oil, air, lens as such can block the pupil in cases of microspirophakia, or anteriorly displaced lens, and inflammatory causes. Other spectrum, the whole spectrum is lens induced glaucomas, and trauma also, traumatic hyphema and iritis can cause acute rise in IOP, and other rare causes like Poshner-Shosman syndrome. So coming to acute angle closure glaucoma. So when you see a patient coming to your OPD with severe debilitated pain and redness and loss of vision, so you examine the patient and then you see severe corneal edema, circumciliary congestion. Vision is usually in the range of 660 to hand movements. IOP will be very high, usually over 50. And if you see the AC, it will be very shallow, and mild AC reaction and flare will be there. And the prominent sign in this will be a fixed dilated pupil because of the ischemia. And if you see the fellow eye will show an occludable angle, which confirms the diagnosis of acute angle closure in this attack, in this patient. So how will you manage this patient in your OPD? So in management of any condition involves understanding of the pathology of the condition. So in this condition, so what is happening is there is a primary pupillary block which is causing an iris bombay, and which is secondarily causes angle closure, increasing the IOP and all other signs of acute angle closure attack. So primarily we have to address the first we have to address the aqueous IOP. So IOP can be reduced by aqueous, decreasing the aqueous protection by various drugs, but mainly we use topical beta blockers and alpha agonists. Prostaglandin analogs will be avoided in inflammatory conditions. Orally, azrazolamide 250 mg can be given to acutely reduce the IOP. IV mannitol can be given if the patient is if there is no contraindications to IV mannitol. It's usually given in the dose of 150 to 200 ml, slow IV over 20 minutes. So these can be done to reduce the IOP, so that your view becomes clear to do any manipulation. So other things you can do is to reopen the angle. So pharmacologically, pilocarpine 2% eye drops can be instilled, which constricts the pupil and opens the angle. The iris falls back and the angles open up, so that there will be some aqueous outflow. So there will be a reduce in IOP. Mechanically, you can do corneal indentation with the gonio 4 mirror lens, which again opens up the angle and helps in aqueous reduction. And a clear corneal paracentesis can be done to acutely reduce the IOP, which further helps in corneal clearing and further management. Along with it, always you have to reduce the inflammation, because all these conditions present with severe ciliary spasm, and it adds on to the pain of the patient. So you have to address that also with topical steroids. But the definitive treatment here is to relieve the pupillary block. So all these measures you are doing just to clear the cornea, to make the cornea ready for clearing the pupillary block, to see a good view of the iris, to make a patent PI. So it can be done with the laser peripheral iridotomy, and in rare cases we can do a lens extraction in such cases, but always and always remember, you should do a prophylactic iridotomy in the other eye as well. So pupillary block can also be caused due to silicone oil, which can be trickled post vitrectomy patients, which can be trickled through the zonules, and it can come into the anterior chamber and block the pupil. So it is a kind of a reverse pupillary block. So here again there is a iris bombay formation and secondary angle closure, and the following mechanisms is the same, but just the cause of the pupillary block is different. Even a gas bubble, C3F8 or SF6 can block the pupil, and even a small air bubble which is done post cataract surgery, post uneventful cataract surgery, can block the pupil and cause acute rise in the post-op period. Causes in inflammation will include a seclusion pupillae, which is a 360-degree posterior synechia, which will cause iris bombay and cause high IOP. Occlusio pupillae is just a pupillary membrane, which is again causing an iris bombay and causing a high IOP. So, how will you manage these patients in OPD? First thing is not to get tensed. In any condition of high IOP, you have to just reduce the IOP first with medications, topical, oral or systemic, as in acute primary angle closure attack, and the primary and definitive treatment to relieve the pupillary block will be laser PI. You don't have to wait for pupil constriction or the IOP to come down in secondary pupillary blocks, because it is very difficult to bring the IOP down. You can just take the patient to the laser room and try look for any thin area of the iris and then make a patent PA. In such cases, you have to be careful, because the AC will be very shallow. The iris will be just touching the cornea. It will be just behind the cornea. So you should be careful not to injure the cornea as well. And once you get a patent iridectomy, you can see beautifully the iris falls back, and even the finger tension becomes normal. And in some cases, you can even see the cornea clearing immediately. The other lens-induced causes include microspirophakia, where the lens is small. It is a congenital disorder where the lens is small, the equatorial diameter is small, so that sometimes it can get subluxated when the patient is bending forward, or spontaneously it can get subluxated, where it can get trapped in the pupil and cause secondary angle closure, iris bombay and angle closure. In cases of pseudoexfoliation, the normal crystalline lens or a cataractous lens can forwardly displace and get trapped in the pupil and cause a pupillary block again. So, how do you manage these conditions of microspirophakia, where there is intermittent subluxation of the lens? So, any condition, you have to first medically control the IOP as acute primary angle closure. But here, to relieve the block, you can try cycloplegics, because the smaller lens is trapped in the pupil. So, once you give a strong cycloplegic, and make the patient supine for 1 to 2 hours, sometimes the pupillary block can get relieved in microspirophakia and the lens can go back to its original position. If still the block is not relieved, you can attempt laser PI. But the definitive treatment in any microspirophakia case will be a lensectomy, vitrectomy with secondary IOL, because they can have again intermittent attacks of this thing, and sometimes the pupillary block cannot be relieved by any methods. Coming to the whole spectrum of lens-induced glaucomas, so the first and foremost comes phacolytic glaucoma. So phacolytic glaucoma is the release of high molecular proteins through an intact capsule in a hypermature or mature cataract. So usually the patient presents with acutely elevated IOP. You can when you check the AT, the knob moves on. The first patient I saw, when I was checking the AT, it is going from 0 to again 70. It is coming back to 0. So it's almost more than 70, or it's unmeasurable. So such it usually presents with such a high IOP, and the patient presents with severe pain, redness, and discomfort. So main thing is you have to reduce the ocular IOP with ocular hypertensive medication, but the definitive treatment will be removal of the offending agents, which is the cataract in this condition. So you have to plan for a cataract extraction. You can plan under IV mannitol cover, because even though you are trying to reduce with medications, it may not be reduced to that extent you are expecting. Coming to phacomorphic glaucoma, so normally there is a phacomorphic narrowing of the angle, which generally occurs slowly with the formation of cataract. However, in some acute cases, which the incipient stage of the cataract where the lens is swollen, the iris comes in touch with the lens capsule more easily and causes a pupillary block, sudden pupillary block, and in an eye which is not anatomically predisposed, this can happen, and sudden iris bombay and angle closure can happen. There is a controversy in the treatment of this condition whether LPA should be done prior to cataract extraction or not, but the definitive treatment in any case will be cataract extraction, because that is the offending agent in this condition. Coming to trauma, especially blunt trauma, there is hyphema, where there is the dispersed RBCs in the anterior chamber, which can go and clog the trabecular meshwork directly, or the inflammatory debris and the fibrin, which can go and clog the trabecular meshwork, or there can be a direct injury to the trabecular meshwork, which can increase the IOP. There can be many mechanisms, but the patient presents with acutely high IOP and a loss of vision. And in hyphema, the prognosis depends upon the level of hyphema, the grade of hyphema. Sometimes there is a total hyphema where which can again cause the pupillary block and angle closure type of glaucoma as well. So how do you manage these conditions in OPD? So medically you have to advise first rest and head and elevation, and steroids and cycloplegic should definitely be given to take care of the inflammation and the ciliary spasm which is happening, and anti-glaucoma medications to reduce the IOP should be given. In particular, carbonic anhydrase inhibitor should be avoided in these cases, because in sickle cell hemoglobinopathies, because it can aggravate the acidosis and cause more sickling. Antifibrinolytics agents have also been tried, tranexamic acid, TPA and aminocraptoic acid, which are mainly useful in rebleeding cases as well. In some cases of hyphema, we need to intervene surgically. The surgery will be an AC wash of the hyphema. In very rare cases, filtering surgery also may need to be done to take care of the IOP. So what are the indications of AC wash in these patients? One is the corneal blood staining, because when the hyphema is there in the anterior chamber for a long time, like more than 48 hours or something, the corneal blood staining can happen, which is an irreversible damage to the endothelium, which can lead to vision loss. So that is an indication. And any IOP of more than 60 mm for 48 hours can affect the optic nerve, so that has to be evacuated immediately. And any IOP more than 50 mm for 5 days and any IOP more than 35 mm for 7 days also needs an AC wash. But lower threshold of IOP in these cases has to be kept in mind for sickle cell disease and trait, and also in young children with because they have a risk of amblyopia. So coming to Postular-Schwarzman syndrome, this is a very rare syndrome. Patients usually, it is usually in the younger age, patients present with unilateral recurrent episodes of acute IOP. They will present you with pain and blurred vision, but there may not be redness as much. It is like a white eye condition. There will be a mild anterior chamber reaction. Sometimes a sentinel KP can be seen. The treatment again will be topical steroids and anti-glaucoma medications during the episodes, but otherwise in between the episodes they may not need any treatment as such. Thank you.
Thank you, Deepika, for that informative talk. It was, you have covered all the emergencies.